Yes, so thank you. Just a quick disclaimer, I'm not Nico Gustschin, I'm his stand-in because Nico couldn't attend the conference himself. Yes, in my part of the talk, I want to continue what Manuel has already started and talk a bit about the performance and the potential of our system. And first off, I, however, want to give a quick background about the first dark field CT scanner that also used a rotating gantry. Here you can see that this system was used to perform small animal studies. And what's also quite immediately noticeable is that the lung in particular here shows a quite slow signal. So lung imaging is immediately an interesting candidate for analysis with dark field imaging. Now, this system used a 35 kVp spectrum, so it was using a quite soft spectrum. And also the field of view back then was quite small with about 3.5 centimeters, which of course was suitable for small animal studies. And also this system used a so-called step and shoot acquisition, which basically means that the gantry had to stop at every angle and then multiple images were acquired. And this meant that the overall acquisition time with this system was quite slow, of more than 40 minutes. So this is not really feasible for a clinical use. However, with the system, one could first perform CT imaging on living subjects and analyze the effects of different pathological changes in the lung tissue. And for us now, however, it was the challenge to translate these parameters and bring them in a more clinically usable range. And so for our prototype scanner, we are currently using an 80 kVp spectrum, as Manuel already mentioned. And this is related to the fact that we need to consider our gratings here and need a harder spectrum would then mean that we need higher aspect ratio gratings. Furthermore, we are currently using 550 milliamperes as a current, which is basically the highest setting our system offers currently. And we are also trying to use the smallest focal spot that's possible. And this is because of the effect of beam shadowing, which you can see on the right side. So as you can see, this large focal spot has some rays that hit our grating lamellas here at a slight angle. So they don't penetrate the grating as designed anymore. And this decreases our interferometer performance. So to mitigate this, we need a small focal spot. Yeah, our field of view is obviously a bit larger nowadays. We are operating with 45 centimeters here. And currently all of our acquisitions are performed with a continuously rotating gantry using 32 detector lines. And to make prototyping easier, we are currently focusing on axial acquisitions. And lastly, currently we perform all of our scans with a 1 second rotation time. This has two reasons. The first reason is that we need a fast sampling of our stepping curve. And the second reason is that it allows us to apply more dose. Speaking of the dose, we performed measurements of the perceived patient dose with a state-of-the-art measurement. And here we found that we measure a CTTI value of 7.4 milligrays with the parameters I've just presented to you. And this slightly low value is due to the fact that we lose quite a bit of radiation in these two gratings up here. However, if we compare this to clinically acceptable ranges for routine adult chest protocols, we can see that we are quite nicely within range here, which for an initial prototype system is quite good, I think. Now, before I move on and show you first results, I also briefly want to talk about signal calibration, because the dark field signal we are measuring depends on multiple factors. So, for example, the interferometer sensitivity is quite important for us. Then, of course, the sample thickness and the positioning of the sample within the interferometer. Then the X-ray spectrum, and finally also the feature size of our microstructures, which in the end is what we are interested in. So for signal calibration, we propose these dark field Hounsfield units. They are defined quite similarly to attenuation-based Hounsfield units. However, since water is not showing any small angle scattering behavior, we need a different reference material. So here we are currently using neoprene films because, as you can see here, these neoprene films show a similar microstructure as lung tissue. So all of the scans I'm going to show you now are calibrated using a type of neoprene foam. Now, the first scan or measurement I want to present to you is this multi-material phantom as a proof of concept. This phantom consists of multiple plastic tubes that are filled with different materials, and we also have this POM cylinder here in the center. Now, if you focus on this POM cylinder and this water cylinder here in the attenuation, you can see that both attenuate the radiation quite strongly, so we have a strong signal here. However, both don't show any small angle scattering, so they vanish in the dark field channel. If we look, however, at this neoprene cylinder here, we can see the neoprene doesn't attenuate a lot, but it scatters quite a lot here in the dark field signal. Now, the big advantage of CT measurements is, of course, that we also perform a quantitative analysis. So we can plot all of the material values here in this coordinate system with the attenuation on the x-axis and the dark field on the y-axis. And what we immediately can see here is that both are not immediately correlated, but in fact, we have two complementary signals that can tell us more about the density of scattering microstructures. So for example, we can pick out these three falcon tubes here on top. They are all filled with wool with increasing moisture. So we added some water here. And what we can see in the attenuation is that the attenuation increases with the increase of water. But since the water also closes up the scattering interfaces, the dark field decreases here, which leaves us with quite a, which leaves us with this trend line here. However, if we now look at the bottom three falcon tubes, we again filled these with wool, but this time we decrease the density of the wool. So in this case, both channels decrease because here the attenuation slightly decreases with the density, but this is hardly noticeable. But we have a strong decrease here in the dark field because again, the scattering interfaces decreased. And this leaves us with this entirely different trend line here. So by combining the dark field and the attenuation channel, we can get new information about the overall microstructure of our sample. And if we now look to pathological changes in lung tissue, we can see that, for example, here in this emphysematous lung, we have a overall loss in the pulmonary structure, which also decreases, again, the density of the tissue. But if we look, for example, to a fibrotic lung, we can see that some of the tissue has been replaced with conjunctive fibrotic tissue, which then again decreases the scattering capabilities of the tissue. So we hope by introducing dark field imaging in this regard, we can improve the overall capabilities of diagnosis and differentiation of different pathological changes. Now, next up, I also want to present you the results of our measurements from the human thorax phantom, which Manuel already talked a bit about. So here we use this human-sized phantom, which has a clinically representative size. And it also features realistic attenuation properties. However, it does not feature realistic small angle scattering properties. So we had to modify this phantom slightly by inserting this neoprene phantom here, which is also filled with a POM cylinder and 3 more plastic tubes. And here on the left side, you can see the results of our first measurements of this phantom. As you can see quite nicely, the soft tissue, quote unquote, here shows a signal in the attenuation, but it vanishes in the dark field. The same thing is true for the POM cylinder, but our neoprene insert can, or really shows a strong signal here in the dark field. And this is a first proof of concept that we can in fact measure an object that is this large and still resolve the dark field contrast in such a large human-sized object. Now, to improve the realism of these measurements further, we also started to use biological tissue. So what we did here was we used a pig lung from a obviously deceased pig. And because the lung collapses on the death of the pig, we had to reinflate the lung with some pressurized air. And afterwards, we placed it again inside of our lungman phantom and performed a measurement in our system. Here you can see the results from this measurement. Again, what you can see quite nicely is that all of the soft tissue around the lungman phantom vanished. And now you can also see that we can definitely get a dark field signal from the lung tissue. And here I should mention that here the signal from the lung is a bit lower than from our reference neoprene cylinder. However, one should keep in mind that, of course, the signal we measure from such a biological sample, of course, also depend on the overall decomposition process of the sample, the fact that this lung is not perfused with blood anymore, and of course, also on the overall ventilation process that we applied. So this dead pig lung is probably not a one-to-one reference of a healthy living pig lung or lung of a human. Okay, finally, I also want to talk briefly about non-clinical applications of dark field CT imaging. Here you can see a measurement of a filled backpack that we did in our system. As you can see, it was filled with various materials. So here we have a water bottle and here we have a towel. And again, you can see quite nicely that this water bottle vanished in the dark field. So it should be here. And what's interesting is that here, this container that was filled with baby powder here looks like it is a compressed object in some way, so a solid object. However, in the dark field, we can see quite clearly that it's actually a powder because it scatters quite a lot. So one immediate application of dark field imaging would be security applications, because we can quite nicely detect microgranulates and powders. Another possible application is in archaeology, where we can use dark field imaging for organic remains or the analysis of fabrics. And lastly, also there are industrial applications in non-destructive testing, or for example, there have also been performed studies on the transport of water in cement. Now, as a brief outlook, I presented to you the results from the first medical dark field CT prototype. We could prove with the system that we can perform quite fast data acquisition on the second scale. We are able to use a sufficiently large field of view for human-sized objects, while still using clinically conceivable doses. By using this new modality, we can get sub-resolution information about a sample's microstructure, and we hope that this can improve tissue characterization and diagnosis of lung diseases. Furthermore, because we are now able to perform this measurement in a CT environment, we can now perform quantitative analysis. And this is especially valuable when combined with the attenuation channels. So basically the combination of both channels together. Now, as a brief outlook, we want to optimize our system further. And this means that we need to improve our processing and, of course, also the scan parameters further. So one field of research that might be interesting here is iterative reconstruction, because as you've already heard so far, we are using a sliding window type approach, where in the end we use a filtered back projection. So we might benefit from iterative reconstruction. And lastly, we of course also want to perform helical acquisition. And here on the right side, you can see the first two images that were acquired with helical acquisition. Again, here we measured our lung band phantom. And yeah, so that's just a small teaser of what's hopefully coming up next. And now lastly, I also again want to mention that if you're more interested in how our processing pipeline works, we've prepared 2 posters on these 2 topics. So yeah, if you want to know more about that, visit us tomorrow at posters 15 and 10. And with that, I also want to thank my collaborators and of course, all of you for your attention. And I'm open for questions. Thank you.
Talk is now open for questions. Emil?
Thanks. Yeah, nice talk. Thanks for that. So most of your biological examples were focused on lung imaging. I was just wondering, is there anything to be gained by bone imaging?
Yes, I think there have been some studies because bone imaging has, so in theory, with this gradient-based imaging, we're sensitive to different directions of scatter. So there have been some studies performed on that. However, at our system, we're probably not sensitive enough to perform something like this currently.
Okay, thank you.
Hi, thank you. Very nice talk. I'm wondering if you can comment on how, for example, the patient's motion, like the cardiac and breathe, will impact this image quality.
Yes, so I guess it's like in any CT imaging that of course it's not that great. However, regarding motion, I can maybe show you this image here again. Because we are currently performing the sliding window acquisition, we are more or less sensitive to fast motion of our sample anyways, because what we have to do is we have to group together adjacent projections and then process them jointly. And this means that if our sample is moving too fast, and here, if the patient, for example, would be completely still, he would still move because we perform a continuous acquisition. And if he moves too fast, then we will see some streaking artifacts or artifacts in the final reconstruction. And you can see this here, for example, in this early reconstruction. However, we improved our processing by quite a lot, I think. And here, for example, in this image, you can see that the table is not generating any streaks anymore, or significantly less streaks than earlier. And I think that in this regard, we are also more robust against movement, at least for a bit.
Hello. What kind of frame rate are you using?
So we can either use or acquire 4,800 images in 1 second, or half of that. And currently we're using, I think, yeah, half of that, so 2,400 in 1 second.
Would you benefit from a higher frame rate?
I think that the problem here is that the flux we can generate is not high enough. Okay. So this is currently more of the issue for us, to apply enough flux, enough dose, so we can see something.
Do you have a multi-energy system?
No.
Like would you benefit from that?
Yeah, in principle, yes, but it of course would also complicate things by quite a lot. So let's first get it to work with one polychromatic source, and then let's see how we can improve it further. But yeah, in principle, of course, it would be nice.
Okay,
because
thank you.
Yeah, the gratings in principle could be built into other systems as well.
Was your CTDI measure using a 16 centimeter phantom?
I'm not quite sure. I think it's the standard for, do you know, Manuel, what we used here?
I think this is the standard body phantom, 32 centimeters of what is material is. I think it's like PMMA with these measuring rods around it.
Okay, the 32 centimeter phantom.
I think, yeah.
Yes.
Okay. Well, it'd be beneficial if you can also measure the noise equivalent quanta for especially for the absorption contrast CT images, and compare that the NEQ with the standard ICT from Pfeiffer.
So you mean a comparison between the modified and the unmodified system?
Yeah, for the noise equivalent quanta for the absorption or attenuation contrast CT in the future.
Yes.
One question about the KVP. So there's obviously a trade-off between you want to not go too low because then you don't penetrate through a large body, but you also don't want to go too high because then you get less sensitive to fringes. Do you feel like 80 is close to optimum, or do you think a little bit lower would be better, or a little bit higher? Where do you think the optimum would be?
So our system does not allow to go lower than 80. So obviously we couldn't test it. What we did test was going higher, and there, from my experience, it is not that helpful to go to higher voltage numbers.
But some systems can go lower. It's possible to go lower, right? You could go to 70 kbp. So do you think that would be better? Or
Yes,
worse?
we thought about that, but we currently, again, our issue here would be that the flux is probably too low. So while the visibility would be quite higher, I don't think it's feasible.
And the images look very impressive, but the artifacts that are remaining, do you think those are primarily noise, or it seems like I also see a little bit of aliasing artifacts potentially? Or do you think
yeah, so what we can see here is definitely noise. And for example, here you can see a remaining artifact from the edge here. And again, here at the table, you can see these slight streaks. And these are these remaining artifacts that stem from the movement of our object, which we try to mitigate with a newer processing approach, but still there are some remaining. And this is, for example, something where I imagine we could benefit from iterative reconstruction techniques, because then we could include the movement of our object into the forward model.
Okay. Now, as a quick follow-up question to Bruno's question. So regarding KV, at least for clinical CT scanner, for chest imaging, we have challenge areas, the shoulder area where you, the top of the lung, you have a lot of attenuation in the lateral direction. So clinically, even 80 kV, once we go large patient, will be very challenging. So we probably scan 120 kV. Even that for obese patient, you might still see strict artifacts there. I'm curious in dark field whether you have similar challenges that you need to go higher kV to make sure penetration in the shoulder area.
Yeah, so we definitely have run into some issues regarding the dose we can apply, or so for the noise level later on, if we measure really large objects. So for example, this lungman has the added possibility of adding some more layers outside here to make it even bigger, and then we can also fill it with more absorbing materials and so on. And then we can definitely see that we slowly run into the problem that our signal gets quite low because our fringes are already quite attenuated by the, or decreased by the attenuation of our object. But the problem is if we go to higher voltages, then also our visibility decreases and the overall performance of the interferometer. So while of course our attenuation image then would maybe look nicer, the dark field image wouldn't really benefit from that change.
Thanks.
Let's thank the speaker again.